Okay, good afternoon. I'd like to introduce myself. I'm Dr. Shelley Brittain. I'm one of the primary care providers here at Evergreen Family Medicine, and I want to thank you all for coming today. Thank you for joining us for this presentation. For those of you who are online too, thank you. I don't know who all's out there, but um, we'll go ahead. So, our talk today is called Heffalumps and Woozles, subtitled "What is delirium and why does it matter?" Um, there's a little background with this. The first part of the background comes from several months ago. I had an opportunity to attend a conference, and it was largely talking about issues in geriatric medicine. Most of my patients are 65 and older. I'm an internist, and I prefer to see older people. It's what I like. The conference was particularly interesting to me, though, and it talked about a lot of things that I see every day and kind of meshed it all together. When we followed up on that, I came back and I talked with Dr. Tim about the conference and what I had learned there. And from that, we developed a section in our monthly provider meeting that we call Senior Moments. And since I'm kind of being senior now, I get to be the senior moment person. So our Senior Moments section has consisted of some tidbits that I collected from this conference that I went to last year. One of the conference sections, though, was about delirium, and today that's going to be our topic. As I was thinking about delirium, one of the images that came to mind was that of Winnie the Pooh, who was a favorite of my children. And in Winnie the Pooh and the Blustery Day, Winnie the Pooh has a dream, and he dreams of Heffalumps and Woozles. Heffalumps and Woozle, a Heffalump or Woozle is mighty confusal. A Heffalump or Woozle is very sly. They come in ones and twosles, but if they so choosels, before your eyes you'll see them multiply. And in this dream, Winnie the Pooh sees all kinds of imaginary creatures that nobody else knows about. And he calls them Heffalumps and Woozles, and they kind of haunt him after that. It made me think of what I see in delirium in my everyday practice. So with that, oftentimes when we do medical presentations, we'll have a patient that we will present as an example of the illness that we're discussing. This patient that I'm going to present is entirely fictional. I picked the pictures off of the internet. I made up the story, but this is very illustrative of what we see in clinical practice. And I think that for those of you who may have experienced severe illnesses with older family members where they actually became delirious, you may see some common threads in this. So I will introduce you to this hypothetical case with my patient that I've named Richard. And for the sake of those folks who are here in the room, I'm going to ask Cody to dim the lights in the front just a bit, please. So Richard is an 82-year-old retired accountant. He lives with his wife. They've been married for 55 years. He loves to garden. He likes a scotch in the evening. Recently, he was rebuilding raised beds at his property. He stepped onto a nail sticking through a board. It went right through his shoe. He took his shoe off, was rather annoyed that it had interrupted his work, and he changed his shoes and socks, wiped it off, and said, "My tetanus vaccine is up to date. I'm good." And he kept working. 3 days later, Richard finally consented to see his doctors. His foot was getting red. His wife was worried about him. He was limping around and complaining. He saw his doctor at the office. Foot was indeed red. Antibiotics were prescribed. He went to his pharmacy to get them, but unfortunately the pharmacy did not have those ready for him that afternoon, and so he went another night without getting his antibiotics. And unfortunately, this part of the story is all too common. The next morning, he went to the pharmacy to get the antibiotics, and before he could make it back home, he fell in his driveway, had his medicines there ready to take. About an hour later than he was expected at home, his wife found him down in the driveway, and much to his chagrin and despite his protest, she called 911. And so he was taken to the emergency department. Now, mind you, Richard is now 4 days past this initial illness or initial incident. He gets to the emergency department, and there he's found to be confused. He has a temperature of 101. His blood pressure is low at 86/40. His pulse is 130, and his respirations are 20. Richard's a sick man. He has spent a couple of hours wallowing around in the driveway, and things are not going well. His wife has arrived and offers some medical history because at this point he really can't contribute to it. She is able to talk with the doctors there and say, well, he has diabetes. No, he doesn't feel his feet very well. He's had diabetes for a long time. He hasn't really complained until yesterday that his foot was that bad. He's treated for high blood pressure. He's had coronary artery bypass surgery in the past. He has an enlarged prostate. Sometimes it's hard for him to make urine. He has arthritis of the spine. This doesn't interfere with him too much, but the scotch in the evening helps ease the pain. And his wife notes that he's confused, and when she's asked about that, she tells the provider that, well, he's a little forgetful. Yeah, he seems to fall more often, but he's always pleasant. He never gets sick. And she's pretty sure he's taking his medicines the way he should, although she's not sure about everything that he uses. In the emergency department, they try to piece together the medications that are prescribed for him. It becomes clear that he uses some insulin and he uses metformin. He's on 2 different blood pressure medicines. She's not sure of the doses. He takes statin for his heart disease and aspirin. Occasionally, he uses some hydrocodone. He uses some sort of medication for his prostate. He uses an over-the-counter sleep medication, some kind of PM, she thinks. And he was started on an antibiotic for the foot infection, but it's still in the bag. He still hasn't had a dose of antibiotic. At this point, we're again in the 4th day after the accident, and Richard's admitted to the hospital with sepsis due to an infection of the puncture wound of his foot. This is a very common scenario. We see people like this every single day that will come in, and this is not unusual. That night, Richard becomes really confused. He pulls out his IV line and he takes off his gown. He can't find the bathroom. He ends up in the hall and wanders into another patient's room. And then when the staff asks him to return to his own room, he gets really angry and he's confused. He's finally persuaded back to his room, but confusion worsens and the night doctor is called and they prescribe a medication to try to decrease his agitation. Now, mind you, he's gotten all of the other medicines that he needs at this point. He's got medicine for fever. He's gotten antibiotics. He's getting some IV fluid, but that's been interrupted. He continues to call out for help. He doesn't understand that the TV remote is not his phone, and he wants his wife, and he wants her now. He gets moved to the special care unit during the early morning hours, and they actually have to put a vest restraint on him to keep him from crawling out of bed. It's been a really hard night for Richard. The next morning, he's really hard to awaken. He's incontinent of urine. His vital signs look better, but when his wife comes in, he doesn't recognize her. She waits patiently in the morning, and the doctor finally comes in, and she is just beside herself and said, "What happened to my husband last night? He is never like this." And again, we're seeing a very clear picture of delirium. So when we talk about delirium in medical terms, there's a fancy definition. A clinical syndrome that usually develops in the elderly is characterized by an alteration of attention, consciousness, and cognition, with a reduced ability to focus, sustain, or shift attention. More simply put, delirium is acute brain failure. The brain is just not processing things correctly, and we call it lots of different things in the hospital setting, and even after that, you may hear it referred to as altered mental status, acute confusional state, acute brain syndrome. Probably the most common thing I see right now is toxic metabolic encephalopathy. We often see that confusion. We often see things described in that way. But I think that one of the ways that we, both as medical providers as well as patients, should consider this acute brain failure is that this is a medical problem that's clearly associated with increased morbidity, meaning that there are lots of current symptoms and problems associated with it, but also with increased mortality or risk of death. So there are a number of risk factors that are to be considered and that we look at as medical professionals that put people at risk for developing this sort of confusion. Age more than 70, an underlying diagnosis of dementia, functional disabilities, and by that we're speaking of people who perhaps don't walk well to begin with, don't hear well to begin with, people who have appliances that they need, people with developmental disabilities, anything that keeps folks from functioning at a usual level. Interestingly, males have a greater incidence of delirium than do women. Poor vision and poor hearing, both of those are risk factors for delirium. Mild cognitive impairment as opposed to dementia, and that's really mild cognitive impairment is considered something that there's some forgetfulness, but a person still maintains their ability to take care of themselves in a meaningful way every day. They probably aren't doing calculus anymore. Lots of us in this room probably aren't, but they do have some short-term memory impairment. Alcohol use problems certainly increase risk of delirium. And then there are various lab abnormalities that we might see, whether it be very high blood sugar or low blood sugar, underlying infection, problems with potassium, magnesium, such as that. Things that will actually cause delirium to occur can include, or things that contribute to this can include medications, and there are a number of medications, and we'll talk a little bit more about that. Surgery. A lot of people are very confused after surgery, not only because of medications, but because of anesthesia that is given. Hypoxemia, that's the medical term for low oxygen levels. And as you might imagine, if your brain's not getting enough oxygen, then it's not going to work well. Untreated pain, and that, again, sometimes, especially if a patient has other risk factors for dementia, or delirium rather, such as dementia, it may be hard to recognize that their confusion is actually their inability to express the fact that they have untreated pain. Infection is a huge one. Infection with fever is huge. Acute illness of any sort. And then an acute exacerbation of a chronic illness. And probably the most common thing that we see that causes that is when people have worsening of chronic obstructive pulmonary disease. Because not only are they ill, they're struggling to breathe, they have low oxygen levels. There's a lot of panic with that. For people who are highly vulnerable, and we will often see this in the assisted living and in the memory care facilities, if a person becomes constipated, they can certainly become confused. And it's hard for those who don't have that problem, it's hard to imagine, but it does happen. A person that becomes dehydrated can become confused. Sleep deprivation, and that one pretty much makes a lot of sense. And then urinary retention. And I can think of more than one time in my hospital work where we've had a patient that has had some dementia. They have been in bed. All of a sudden, they're incontinent. Staff thinks that they're urinating okay. And the problem is, especially in men, men who have enlarged prostates really don't urinate well in bed at all. It's hard for those gentlemen to empty their bladder without standing up. So if they're restrained in bed and they can't empty their bladder, they've got a big full bladder that hurts, and it may be difficult for them to express that. When we're in the hospital, this occurs, we'll see this in the general floor patients somewhere between 11 and 42%. Some studies have shown. In ICU, it approaches 90%. And again, I would say that's pretty darn accurate. In the intensive care unit, people are terribly confused, and they have lots of those risk factors. Here's an important thing to think about, though. So if a person is delirious, and again, thinking about that as acute brain failure, if they're delirious during their hospitalization, 45% of them will remain somewhat delirious at discharge, with up to a third still altered a month later. So that speaks to how we may want to approach folks when they're initially discharged from the hospital, both here in the clinic, but also at home if they've been confused during their hospitalization. So one of the things that I asked of our providers when I talked about this is, do we really recognize delirium? Because sometimes I don't think that we do. I'm not sure that I always do. There are two main kinds of delirium that are noted: hyperactive versus hypoactive. Hyperactive, we all see that, somebody that, and that is the person who's agitated. They want to get up, they want to take their clothes off. This can be the meekest, mildest. This can be the head deacon in your church, but he can come in and all of a sudden he is wandering around the hospital wards naked because he's confused. So that's that psychomotor agitation. The person is restless. They are emotionally labile. They may be happy one minute and crying the next, then angry the next, versus hypoactive, which means they're not very active at all. And these are the people that we see that really don't respond properly. I think the most striking example that I would think of with this would be people that I've seen after a stroke. It's not at all unusual after a person has had a stroke of any sort to see them be really sleepy for 2 or 3 days after that. And then all of a sudden they just kind of wake up and you have a better idea of where they're going to be thinking. This person is very lethargic. They have a decreased level of responsiveness. Sometimes it's hard to know whether that's a medication effect or whether that is a manifestation of delirium. If it is prolonged, we can certainly mistake that for depression, as opposed to those, who are hyperactive, and we may be concerned that that person has become psychotic. For our patients who have underlying bipolar disorder, they may be in a manic phase. And then again, we do have some dementia patients who actually will manifest their illness through pacing, walking, such as that. And it may be confused with that aspect of dementia. So why does recognizing delirium matter? Well, number one, we want to keep folks safe. But number two, I think it helps us with helping to make some plans for that person, especially if they clear. From a healthcare perspective, and there's a lot of emphasis on costs in healthcare. These are some old numbers from a 2009 study. You can imagine that would have increased significantly since that time. But it's estimated that annually, delirium accounts for $38 to $152 billion a year. And that's an amount that I can't even fathom. But when we compare that to other very common things that that we may think of more frequently when we're talking about hip fracture, non-fatal falls, complications of diabetes, and even cardiovascular disease. You see everything there aside from cardiovascular disease falls below the line of where delirium is projected to be. And delirium certainly occurs concomitantly with all of these medical problems that we see listed here. So to you and me, what does this mean? You know, that's all really good for the numbers are good for the number crunchers, but for you and me, we need to know what it is that we're taking home from the hospital, or how we may be affected going home from the hospital. The thing that I think that was most striking to me was realizing that most of, or many, I won't, not most, but 40%, so nearly half of the folks who develop hospital-related delirium will never return to their previous level of function. The 1-year mortality rate for hospital-induced delirium is 30 to 40%, which is the same risk of death as if a person has a heart attack or if they have a septic event. And that's a big number. Again, as I mentioned before, and I'll reiterate this, for a third of the patients who have delirium in the hospital, they will still have some element of delirium 1 month after their discharge and will continue to need additional assistance at home. So this is where we really look at it with, okay, we're planning to go home. This person has been confused. What else are they going to need? Are they going to need to be in skilled nursing for a while? Are they going to need home help? Are they going to need physical therapy, occupational therapy, and such as that? When we talk about ADLs, or activities of daily living, we're talking about the basic things that you and I do to take care of ourselves every day. We're talking about being able to feed ourselves, to be able to go to the toilet independently, to be able to bathe independently, to be able to put on our clothes, to be able to walk independently. Those kind of things are what we're talking about. When we will have a person that will come into the hospital and have delirium, basically there's some studies that suggest that a person who has had delirium will have a loss of one activity of daily living with every delirious episodes, if their decreased level of function lasts 6 months. So if you're talking about somebody that has gone into the hospital 2 or 3 times, even 4 times in a year's time, we've moved from somebody who's able to take care of themselves, although it may be marginal, to somebody who now requires full-time care. So this is pretty grim news. I mean, none of this sounds particularly good. Is there anything good that we can look at here, and how can we prevent delirium? So there are studies that have been done as far as things that traditionally we have not been good about in the hospital setting, to try to help patients do better. And that has changed even in my 30 years of practice in what is expected. One of the things that I think has changed the most is the real emphasis on getting people out of the hospital early. And sometimes that seems really hard for families and patients to endure. But if we can get folks out early, overall, they tend to do better. In the hospital, we really work on trying to focus on maintaining their orientation to what's going on. Virtually any hospital room that you go into, you're going to see a whiteboard in there. You're going to see some kind of calendar. They're going to write the day of the week on the calendar, some orienting information, day of the week, date, time, things to expect that day. All of those things are going to be in there. And we try to reorient patients as to, okay, it's daytime, nighttime. One of my habits, if I go in at noontime and all the curtains are closed and the person's in there and it looks like a tomb, I will always ask permission to open the curtains, because people need that daylight. Otherwise, they're going to get their days and nights mixed up. Early mobilization, getting folks out of bed. There was a time when, in my grandmother's era, that if you went to the hospital and had a baby, you didn't get out of bed for a week. Um, those days are over. You're lucky if you get to spend the night in the hospital for many things now that would, even 10 years ago, folks would have stayed in the hospital for. But our effort is to get folks up and moving as soon as possible. The medication reconciliation is huge, and it's one of the places where we really work to try to make sure that when folks leave the hospital, they have a very clear understanding of what they should and should not be taking. We really try to make sure that we understand what they have been taking at home, and oftentimes we'll ask family members to bring medication bottles back in. We really work to try to, as I've alluded to before, help people understand days and nights, because that gets really mixed up. And so there's an effort to try to minimize waking folks up at night. I remember one of the most frustrating times that I can tell you of my own experience in the hospital. I was staying with my mom overnight in the hospital. And this has been close to 30 years ago. Well, that's probably 25 years ago now. I remember we did not see a single person come through the door between about 5 o'clock in the evening after supper was delivered till about 11 o'clock at night. And then from about 11 to 3, there was like this parade of people that came through. And I remember at one point being really annoyed and saying something. I was already in medicine at that point. I had no idea that people got interrupted that much in the hospital. And I think having to live through some of that really gave me a new understanding of where folks were with having their sleep so very disturbed. The other thing that's really huge, especially for our older patients, is to make an effort to address visual and hearing defects. And I would add to that one, and I should have, dental defects. We'll have folks that will come to the hospital. They don't have their glasses, they don't have their hearing aids, and they may or may not have their teeth. And folks need those things. So family members can bring those things in. And then in the ICU situation, it is common now to interrupt sedation every day and allow patients to arouse more, to try to see if they can follow commands, try to get them oriented. Ventilator support is a hard thing to talk about with regard to delirium, because of that in and of itself is a somewhat fearful experience for patients, and we don't want them to be fearful, but typically the intensivists will offer a sedation break during the day. After the hospital, the things that I'd mentioned before are really helpful, and we really encourage, if folks need physical therapy, if they need occupational therapy or home health, that those things be arranged. Some patients feel a little overwhelmed by that, but it's really good for folks to have that support, for the family members to have that support and know that they can ask patients to move and to learn to dress themselves, to ask questions about medications. It's really important for patients to understand which medications have been changed. One of the practices that we have adapted here within the last couple of years, and that we've really emphasized over the last year, is we will call every single patient that is discharged from the hospital, or every single patient that's discharged from the emergency department within 48 hours of their discharge, to make sure that they understand what went on, at least get a big idea of that, but primarily to make sure that they understand what medicines they should and should not be taking. And then after the hospital, one of the things for patients to ask when they go back to their provider is, how can I prevent future problems? With that, along that same line, we make an effort to get every single patient that is discharged from the hospital back into the clinic within a week. again, so we can reconcile those medications, make sure that labs have been ordered as needed, that any supplies are needed, that therapies are ordered if they could not be arranged before discharge. Educational programs may be helpful, um, whether it be cardiac rehab, whether it be dementia support group for families, whether it be our diabetes education group, um, whether it be any of the community programs to assist with ongoing medical concerns. We have a team here of community health workers as well as chronic care management workers who help to bridge some of those gaps that are hard to uh, take care of independently, and those folks do a tremendous job. We've had things like um, arranging for meals, anything from arranging for Meals on Wheels to having a ramp built on the front of someone's house through our community workers. And then a couple of other things, and I think this is really important, both for providers to consider as well as patients to consider. If there's been a hospitalization where there's been significant confusion, I think it's really important that patients have designated the person that would be able to make healthcare decisions for them on their behalf if they were not able to do so. And that's what is implied with an advanced directive document. With regard to the pulse, that's the physician order of life-sustaining treatment. And this is where a patient will express their wishes about whether they want advanced cardiac life support, whether they want ventilatory support, and such as that. So our best efforts really at preventing delirium or taking care of ourselves now, because it takes years in the making to develop the healthy habits that will help us to grow old more readily and more healthfully. The habits that really matter are maintaining good sleep habits. Many of our patients, after they retire, they don't really have a schedule anymore. And before we know it, we've got folks that are coming into the office and they say, well, I don't usually go to bed till 2. I might get up at 11. Well, that may not be the most healthy thing because they're missing a lot of time that they can be up and active in the daytime. Truthfully, healthy eating translates into a healthier life. And I think all of those things that we were told when we were little kids about healthy eating, it really does matter. We're in a country where we have lots to eat, which is a real blessing. We have lots to eat. But the other part of that is that in many regards, our availability of high calorie, easy to eat food has caused us problems with our metabolism and with many other complications that we probably need to rethink some of those things. This is a hard one with every year that passes, but our bodies are meant to move even if it hurts. And I can think of some of my folks that are very vigilant about their exercise. One of the best examples that I can think of was my grandmother, who lived to be just past 100. And I remember when I was a teenager, her talking to me about doing exercises. And she said, and you just need to do that for your posture. And she had actually instructed me to get soup cans and to do arm curls with soup cans because that's what she was doing. And she had to walk every day. When she became too unsteady to walk, she would take herself around in her wheelchair with her feet, and that was going to be her exercise for the day. One of the hardest things we all do as we get older is to maintain a healthy weight, and that is a struggle for all of us as we get older. Avoiding tobacco and other recreational drugs. Tobacco in any form is going to be a problem, and with other recreational drugs, chiefly marijuana, one of the things that I will say to my patients is that there's nothing that you should put on there. You should never put anything that's on fire in your mouth. It's just not going to turn out well. So, avoid tobacco, avoid recreational drugs, avoid putting burning objects in your mouth. Okay. And then finally, avoid excessive alcohol use. There has been a lot of information about uh, how much alcohol is actually healthy. There are some studies now that suggest that probably none is good for folks. There are other older studies that suggest that a glass of red wine is probably fine every night. Um, General rule of thumb with regard to men, no more than 2 drinks in a day, for no more than 14 drinks in a week. For women, no more than 1 drink in a day, no more than 7 drinks in a week. And those are the smaller sizes with 6 ounces of wine, an ounce and a half of uh, hard liquor, and 12 ounces of beer. So when I have a patient that comes in and says, well, I drink 2 beers a day, but they're the big 20s, that doesn't really count. So finally, and I think this is probably one of the places where I see some of the most confusion and the most overuse of things that are available is with regard to medications. And I think it's really, really important that everybody understand their medications. Um, there, there are medicines that are associated with anticholinergic activity. And basically, that is a metabolic pathway that results in the things that I hear lots of complaints about. When patients come in to me and they say, I have terrible dry mouth. I'm having difficulty with urination. My eyes are dry. I'm constipated. All of those are typically related to anticholinergic side effects. Over the counter examples, Benadryl, Unisom, Dramamine, any of the PM drugs, all of those antihistamines have huge anticholinergic side effects. And if we think, and we can think back to our case patient, Richard, who had prostate problems and liked to typically take a PM medicine, and then he was in bed and couldn't get up. Again, he probably had a very full bladder and just couldn't tell anybody, which increased his confusion and delirium. So we think about these drugs. I really strongly encourage my senior patients to avoid all of those antihistamines. With regard to prescription medications, I ask you to know why you take every medication that is prescribed. And I will make it a point to sit down with patients. If they don't know what they're for, I will print off a list of patients' medications and I will write in everyday terms what every medication is for. I have a patient downstairs right now with my assistant who brought in a big sack of medications because he had gone through and nodded his head, yes, 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 to everything he took when I talked to him this week. But then when I pinned him down on one medicine, he goes, I don't know what that's for. And I said, well, do you take it? Well, I'm sure I do. You've prescribed it. And I said, but do you take it? Well, and then he didn't know. And then when I teased it out further, he really wasn't sure about lots of his medicines. So they're going through that right now. I strongly recommend that you keep an accurate list of your medicines in your wallet. I think that your spouse or significant other needs to have that same list and it needs to be updated. And it is very uncommon for me to have someone come in to see me and say, well, I have a list of my medications right here. It's a list that I printed off for them 2 years ago, and we've made changes in the meantime. So no, that list doesn't count either. Okay. And then finally on supplements, most of these are completely and totally unnecessary, completely and totally. Last week I saw a lady who is very health oriented. She exercises regularly. She's very fit. Nobody in this room would guess her age. She's on very few prescription medicines. She had literally a list of 10 supplements that she takes. And I asked her what they were for. I couldn't even pronounce part of them. And I said, what's this one for? Her husband gives it to me. And I said, these are the ones you need. And I picked out her vitamin D and her multivitamin. And I said, the rest of them, you just need to save your money. You're eating well, save your money. And she kind of shook her head. Now, whether or not she's going to believe me about that or not, I don't know. But nonetheless, we got rid of 10 things off of her list that day. So, with that said, I've talked a lot. I would entertain any questions that anyone might have. Yes.
What tools do you recommend for patients to use to make sure their medications are they're taking and consuming them appropriately? Like you see them Monday, Tuesday.
Right.
Are there any other?
Actually, so for those folks online that may not have been able to hear, the question was with regard to assuring daily adherence to recommended therapies, as far as using a pill minder versus other tools. The pill minder is really helpful, but with that, number one, you have to make sure that the patient knows what day of the week it is. Number two, you need to make sure that they're putting the right things in the pill minder. So that and I will specifically ask about those things. Um, it is it is really surprising how many folks are not sure about that, or a family member will say, "Well, I've filled it out," and I call her and ask her to take it every day. But then when the patient comes into the office, daughter has been by to pick them up, and they'll notice that the wrong days are gone or a day is gone ahead of time. So that is a potential hazard for a memory impaired person. One of my colleagues had her late father had fairly advanced dementia before she was able to get him moved in with her. And she had a caregiver that went in and checked on him every day. But they actually make these time release pill containers where you can set up the pill container with an alarm and the dates and a time of day that they should open. And so that's helpful. If a person is not terribly memory impaired, then the phone calls will be fine. But if they've got significant memory impairment, likely as not, they're going to forget on the way to the pill box what it was that they were going to do. And they're certainly not going to set their pills up correctly. On the other hand, I've had some patients who had fair memory impairment, and once they got their boxes set up and they knew it was morning, noon, and night, if they had a regimen and a very strict way of doing it, they did pretty well with it. But that's the only alternative thing that I know of.
But so much of that social support, that's so important.
Absolutely it
Figuring
is.
out if a system will work for them, and if not, then you just need that person needs the help.
Yeah. And that's the other, that's the other challenge that I have, is getting a person to accept the fact that they need that help. I can think of another pair of patients that both of them have gone to the hospital on more than one occasion um, with exacerbations of their chronic illnesses, and it's simply because they weren't taking their medicines correctly. They would require actually less medicine than was prescribed to be stabilized at discharge. They'd come back in and things were out of control. And I would encourage them. I mean, they were in a situation where they could hire help to come in and make sure they took medicine morning and evening. But then they felt like, well, we've got this, and they fired the help. And, within months, we're back at the same place. And it's unfortunate, but it's also part of being free to do what you want to do. Some folks are more willing to allow for help than others are. Yeah. Mhm. Are there any other questions? Okay. I want to thank you all for your kind attention. I want to thank you for coming this afternoon. I will share that I do have some references that I used aside from those that were noted within the slideshow. And I will be here for a few minutes to answer any questions in person if you'd like. But thank you again for attending our Evergreen Talks.